title is Long COVID, a True Autonomic Dysfunction. So the whole thing is the mechanism of oxidative stress. When a virus hits the body, it takes over the DNA and starts replicating inside the cells. And the mitochondria are the factories of the cell. They make ATP, the energy molecule. If your ATP is depleted, one of the major symptoms you'll get is fatigue. And so chronic fatigue type syndromes can evolve because of ATP poor production, which is probably a mitochondrial acquired disorder. And viruses are oftentimes the culprit in causing this. Nerve cells, including the brain cells and neurons throughout the nervous system, have the highest concentration of mitochondria, up to 2 million per cell, whereas a heart cell might have only 2,000. So it stands to reason that a virus will affect preferentially the nervous system and cause nervous symptoms because there are so many mitochondria that can be affected. The density is so high. So the virus plunders the mitochondria and causes what we call oxidative stress by producing chemicals called free radicals, which are very damaging. It's highly toxic to the nerves, and oxidative stress ages skin cells and damages all cells, not just the nervous system. But it's treatable. Now, the parasympathetic and sympathetic nervous systems are involved because they're part of the nervous system with a lot of neurons, and when a virus affects the body, these are particularly vulnerable nervous systems that get affected. The parasympathetics are the brakes of the body, the vagus nerve, the longest nerve of the body, is an example of a parasympathetic nerve fiber. And it goes to many, many organs. The sympathetic nervous system is the adrenaline of the body, the accelerator of the body. You've heard about fight or flight. That's a sympathetic response. Parasympathetic slows things down, sympathetic speeds things up. And we monitor these because it can affect your life expectancy and qualitative symptoms.
Dr. Patrick, have you seen my toy?
Yes, we're going to talk about toys in a minute because toys can stop, like the brakes of a car. The vagus nerve is the brakes of the body. And toys like the car can get accelerated, and that's the sympathetics of the body. Is that a good idea?
Yeah, Dr. Patrick, that's it.
So we make the sympathetic and parasympathetic nervous system analogous to a car. It could be a toy car, it could be a big car. It could be a big car or a toy car. And what happens is that we hit one button, the brakes go on. That's like the vagus nerve all of a sudden going on. We hit another button and a sympathetic fire, the accelerator goes on. Same thing with the body.
Yeah, but if you press if you do that, if you go up, it makes it go super fast.
Okay, he's going to be intelligent. Even a child can understand the analogy of the sympathetic and parasympathetic nervous system with the brakes of the body. He's got energy. Now here's a boy with a lot of ATP. His mitochondria are functioning perfectly well. And if my patients can be restored to that kind of function, I would have a very successful outcome practice. Because that is the whole thing, is to get the mitochondria in the cells working, the factories in the body to make more ATP. And if they're hit with a virus, they get knocked down. Now, why does a young boy who gets hit with a virus not get as much affected as someone who gets older? Well, there's a lot of reasons, and we can get into that. But there are predisposing factors to why some people get a virus, such as COVID, and develop a long COVID syndrome, and some people get the virus, the COVID, and don't develop it. Why are they predisposed? And we can get into that, but age and diabetes and hypermobility, loose connective tissue has been identified as a risk factor. Underlying lung diseases is listed as a risk factor, and so forth. Young people like the fellow we just saw, they rarely get affected with a COVID virus or an Epstein-Barr virus when they're that age. The virus, for some reason, gets taken care of really quickly, and they don't develop these long morbid conditions. Now, cardiovascular autonomic neuropathy is when you have severe impairment of the autonomic nervous system. It can actually lead the cardiac complications, even sudden cardiac death. So it's not a benign disorder. People say, we have chronic fatigue, it's nothing to worry about, you're going to work yourself out. But if the autonomic nervous systems are really deranged, it could be life-threatening down the line, they have to be tested. We just don't know. Now, COVID risk includes not just the virus, but the vaccine. We published a paper that in a major cardiac journal, a review article, that approximately 10% of people who get COVID can go into a long COVID situation, and up to 10%. I think it's closer to 6%. And maybe 2% or 1% with a vaccine could be predisposed to a long COVID syndrome. And that is the basis of that. We talk about antioxidants and anti-inflammatories to minimize the risk, and we do use that in our treatment of patients that have these viral infections that go into a long phase. So what is long COVID, the definition? Well, the New England Journal of Medicine Consensus Group defined it as an impairment and neurological problems, depression, and severe fatigue being hallmarks. 7% of adults and more than 1% of children. This can number up to 50 to 20 million people and 60 million globally. So it's quite endemic or epidemic. No standardized guidelines for developing a disease definition. They use multi-phase processes of systemic engagement, information gathering, include focus group questionnaires and so forth. So no one really has a uniform definition. But just remember, it affects multiple organs, and it can cause severe fatigue, which is a hallmark, and all these other problems. Usually COVID, which goes into the long stage, means after 12 weeks you still have symptoms, is an infection associated with the SARS-CoV-2 infection, and is present for at least 3 months or 12 weeks. It can have relapsing or remitting courses, and it can affect the patient in multiple ways. We just heard how shortness of breath is a common cause of long COVID. How many patients are referred by a family doctor like Dr. Abogani to me as a cardiologist, and everything is structurally normal with their heart? Their stress test is normal, their echocardiogram is normal, and they have these palpitations, pounding of the heart when they stand up, and they're having shortness of breath. They want to know, why am I short of breath? Then I send them to the pulmonologist, like Dr. Punana, who does pulmonary function tests, all kinds of provocative tests, methacholine, looks for asthma. Their pulmonary function tests are normal. Their CAT scans of the lung are normal. Their chest x-ray normal. Again, nothing structural. Then they're having GI problems, and a lot of them get nausea, constipation, bloating, as you see. We send them to the GI doctor to do an endoscope and a colonoscope, and they say you're structurally normal with your GI tract. There's nothing wrong. And then they go to the rheumatologist, because Dr. Abogani will say there must be some autoimmune. We send them to Dr. Soloway, and he does a whole autoimmune panel. He does the most comprehensive one I've ever seen. And you can't find any autoimmunity associated with this entity. He says it's not autoimmune, causing all these multi-system problems: shortness of breath, cough, persistent fatigue, exhaustion, post-exertional malaise, difficulty concentrating with brain fog, memory changes, recurring headaches, lightheadedness, fast heart rate, especially on the upright position, sleeping disturbances, problems with taste and smell, bloating, constipation, diarrhea, some nausea, and so forth. All these organ systems get affected. Yet, if you do a CAT scan in the brain, it's normal. And if you do all these other non-invasive tests, they're normal. So what is it? So the bottom line is, most family doctors or other specialists will say it may be anxiety. They send you to biofeedback. They send you to psychiatry. They say it's anxiety. They say it's depression. And they are pretty dismissal with the patients. When in reality, that is not the case. When you see all these organ systems affected by a virus, or it could be a concussion, it could be a motor vehicle accident, as we just saw the example before, it could be a severe emotional stress, and you see multiple organ systems affected, you can't tie together one theme. Think about the only organ system that goes to all these organs and affects them, and a check and balance system, the autonomic nervous system. And is it out of balance? And I will tell you that most of the time you can reduce it to that. It's an autonomic dysfunction or autonomic dysregulation. We can test for that. If you come to our lab and Dr. Como and I test you, and you test normal, we'll start looking at functional neurological disorders. We'll start looking at the anxiety spectrum of things, primary anxiety, not secondary anxiety, and we'll make the psychiatric referral. But if you test markedly abnormal, then we have to balance the autonomics, because there's something behind all these symptoms. This is the basis of long COVID, a virus affecting the mitochondria, causing multiple organ system abnormalities, and the patient becomes dysfunctional, disabled, incapable of gainful employment, their exercise tolerance remarkably reduced, they're short of breath, yet they pass every test, even in a CPET, which is a very sophisticated shortness of breath test that the pulmonologists do with a physiologist. The reason is because of the autonomic dysfunction. Now, is it just COVID that can cause this chronic fatigue and dysautonomic state? No. The most common one was Epstein-Barr virus, mononucleosis for years, but now that we see COVID, we're seeing the epidemic of COVID. We also see it when enteroviruses have a high incidence of a post-viral long syndrome that can cause that. But it doesn't have to be a virus. Lyme disease can cause that. That's a spirochete. So any infectious agent has the potential to cause it, but right now, 9 out of 10 of them that we're seeing, if you really take a careful history, have been COVID affected. Okay, so definition of long COVID, I just did that one, and we talk about this. Okay, we talked about, am I going the wrong way? I guess I am, right? Let's go the other way. Okay, so as I said, other viruses are known to cause these symptoms, Epstein-Barr, enterovirus, and so forth. The symptoms are not specific for COVID. So everyone says, well, long COVID syndrome is a very unique, esoteric disorder. No, it's a post-viral autonomic dysfunction where we're giving you chronic fatigue and multi-organ involvement. Other viruses have done it. The reason that the public now understands autonomic dysfunction is a very prevalent and real concept is the millions of people that have been hit with this COVID at one time in a short period of time. Now the awareness is there. The Washington Post put out an article about 2 years ago, 4 pages, that there are so many people with long COVID syndrome in POTS, which is postural orthostatic tachycardia, type of dysautonomia. There are not enough physicians in America to take care of them. It's a 4-page article. You're going to look it up in the Washington Post. Very well done. And isn't that the truth? Now people are starting to talk about POTS and understanding, which is a type of dysautonomia. Now they're talking about chronic fatigue being a dysautonomia state. Now they're starting to say it's not anxiety, go see a neurocardiologist or a specialist with autonomic dysfunction and test you. Again, not enough doctors, not enough centers to do the testing, to make the precise diagnosis, objectively follow these people with proper therapy, because it is treatable. It is a slow fix, but it's treatable. Am I going the wrong way again? Okay, so the committee also on low COVID said that diseases like interstitial lung disease, low oxygen diseases, heart strokes, and other forms of dysautonomia and chronic fatigue syndromes can also be present. They talk about fibromyalgia. Now let me tell you about fibromyalgia, and Dr. Soloway will confirm this. Fibromyalgia, if it exists, if it's not just a fabricated term because it's a grab-bag term, we can't put our fingers on what the patient has, it's probably not as common as it's really specific criteria. I personally haven't seen it. But fibromyalgia is not as common as it's being diagnosed. When young people come to me with joint pains, with tiredness, with sleep disturbances, with fatigue, brain fog, orthostatic intolerance, they can't stand up. Many of them are hypermobile with connective tissue looseness. They qualify for Ehlers-Danlos syndrome or hypermobility spectrum disorders. And we renamed the disorder hypermobility syndrome, hypermobility Ehlers-Danlos syndrome, and we cross out the fibromyalgia. We give them the right label, the right diagnosis. So if someone comes in with the diagnosis in quotation mark fibromyalgia, be careful. It probably is erroneous. The same thing with anxiety. It could be erroneous if they have a constellation of symptoms like we're seeing here. So again, to reiterate, many multiple viruses can do this. And we said that you can see these with other viruses. Okay, good point here. There's no blood test or biomarker that can diagnose long COVID. It's a clinical diagnosis. You got to have, by Hill's criteria of causation, you have temporal association. You had COVID within a short period of time. The symptoms following more than 12 weeks. Symptom complex as described in New England Journal of Medicine, multiple organs affected. And Then you can make the diagnosis after you do some objective testing, which is autonomic testing, which Dr. Colombo will address. Simple, non-invasive tests, no needles, no pain, a simple, very, very short test. We can evaluate your autonomic nervous system and tell you, is there a definite abnormality with the autonomic nervous system? If so, and in a proper clinical context, with the proper documentation or history of a COVID exposure or presumed COVID exposure, we can assume that this is a long COVID syndrome, and that was what we're seeing so many people with now. So I saw a billboard on a Black Horse Pike, long COVID stole my life from me. And isn't that the truth? How many people are out of work? How much it's costing the medical system the burden? How much unemployment is costing a burden on the government and so forth? Long COVID is a devastating disorder. It's real and it has tremendous impact on society, not just the person itself. I talked about the Washington Post article, and not enough physicians in America take care of these patients. A condition called POTS, you can't find care for it. Studies have shown anywhere from 2% to 14% of people with COVID develop POTS. But we think and we believe strongly we do have the treatment algorithm for it, which Dr. Colombo may touch upon. Once you diagnose POTS, which is a type of dysautonomia, the person stands up, their heart rate goes to 120, 130, 140, their heart pounds, they get brain fog, they get short of breath. Many times shortness of breath is due to venous pooling in the lower extremity, and you're not getting your heart filled enough with blood to get a good cardiac output. And that's the mechanism of shortness of breath. You treat them with fluids, electrolytes, vasoactive agents like midodrine, compression stockings, and all of a sudden the venous return starts getting better. You don't get the venous pooling. Subjective dyspnea with a little physical therapy gets better in as little as 8 to 12 weeks. Postulated causes of long COVID. Is it direct viral injury? Is it reactivation of another virus that's sitting in your body dormant, such as EBV? Is it autoimmune, or is it a prolonged inflammation with PNS dysregulation, parasympathetic dysregulation? We don't believe it's a direct viral injury per se, although the virus does destroy the mitochondria. That's the main reason, because that comes and goes. We don't believe it's a reactivation of Epstein-Barr or another virus in your body. We don't believe it's autoimmune, although there's been some studies that show that females have a high incidence of ANA that have long COVID, up to 43%. I don't find that. We do find it's a prolonged inflammation state, and we do find that the parasympathetic and sympathetic are dysregulated, and we test for it, and that is the mechanism of long COVID predominantly. We published a study on long COVID with 152 patients in the Journal of Neuroscience, and we showed that we can diagnose it and get people qualitatively better over time with questionnaires following your quality of life indices with appropriate treatment targeting at the testing. Includes pharmacological agents, antioxidants, proper fluid and electrolyte, the proper exercise regimen, which is a low and slow, not an aggressive one, not an intense one, and of course the compression garments on the abdomen, the leg, and so forth. So we've shown that we can get most of these patients starting to get functional within a year's time or so. And again, I reemphasize it's due to oxidative stress, and it is an autonomic disorder. Now, we're not the first ones to show that long COVID is an autonomic dysregulation problem. There are 16 cohort studies besides ours. If you do a MEDLAR search or a PubMed search, 16 studies come up, ours and 15 other ones, and we're doing a little sort of meta-analysis of them now to put them all together and pool them. But there's 16 studies that have done cohort studies that have shown this. There's even more studies, there's nearly 100 studies that have documented in different centers that dysregulation of the autonomics is a main driving force of long COVID. So now it's very widely accepted. It's not debatable, it's not controversial, it's widely accepted. What is controversial is the treatment. Most people say you can't get better, it's got to work itself out. That's not true. We have a long COVID center in Sicklerville, and people say, you know, it's advertised on Cooper or Penn, and we call there and we can't get through to anyone, or we call a place in North Jersey and it's closed now, they closed it down. but they're still advertising, some of the centers are advertising about the long COVID syndrome, but people can't get to them or they're closed down. And one of the reasons I think is that they're not diagnosing and objectively testing these patients for autonomic dysfunction. They're not giving them targeted therapy. They're putting them on antidepressants like Prozac and antihistamines and different anti-anxiety agents, and they're not properly treating these patients. They're not getting better, and they're not getting good outcomes. That's my just fault on the whole thing. So I said we published the first paper. Am I going the wrong way again? Okay, Dr. Klum will just talk about the mechanisms of some of the disorders, but what we basically find is that a lot of these patients, when they stand up, when they're affected by viruses like COVID or any other virus, and they get into a long fatigue state, a brain fog state, a dysautonomia state, they have orthostatic intolerance and can't stand up long periods of time, and we find out that two problems are prevalent many times. One is this parasympathetic excess. They stand up and the vagus nerve gets overexcited. The brakes get jammed on and you can't move your car with the parking brakes on when the vagus is overactive. So we try to loosen the brakes on those. And we also find out with testing, the sympathetics are supposed to fire when you stand up and squeeze the veins to get blood to your brain. And this is an alpha adrenergic mechanism. And that doesn't happen, so the blood just goes to the legs and pulls and stays there. And that's the other reason why these people don't get a good venous return to their heart and their brain, and they get poor cerebral circulation. The younger people get a POTS response, which is a tachycardia when they stand up, because the heart gets small for the venous pooling most of the time, and the heart beats very rapidly. You go to 120, 130, 140. Sometimes we could slow it down with little drugs like propranolol or other beta blockers, but it doesn't take care of the brain fog, the fatigue, the lack of energy, the lack of circulation to the brain. Then you have to add something vasoactive like Metadrine along with all the other modalities we talked about before. So in conclusions, the SARS-CoV-2 virus, by its oxidative stress, can lead to parasympathetic and sympathetic dysfunction, which can coordinate all the organ systems in the body and may explain all the symptoms of long COVID very nicely. We can measure it, diagnose autonomic dysfunction, and therapy directed at balancing the autonomic therapy can lead to a positive outcome, and patient quality of life may be restored. Again, if you suspect that you may have a long COVID patient, we would be glad to see them. We would be glad to see any patient you suspect autonomic dysfunction with, who has a chronic fatigue state, a brain fog state, a concentration problem, shortness of breath that's unexplained by a cardiac or lung disorder, or GI symptoms also that are unexplained by the gastroenterologist. We will look at the autonomic nervous system. We can give you an answer if the autonomic nervous system is normal, mild, moderately, or severely disturbed, and if it is more severely or moderately disturbed, we can attempt some treatment algorithms, and we can see in time if the patient responds. So there is hope for these orders. Thank you very much for your attention. Any questions? Any questions? Yes?
So when you treat it, just you're saying by beta blockers and metronome, or are you using neuromodulators which affects your...
There's a whole algorithm. It depends on the abnormality. Actually, we may use anticholinergic therapy if we think the vagus nerve is a little overexcited in conjunction with the vasoactive agents. And the beta blockers, we try to use in small doses, and only use it if the heart rates are really going very high. But the Metadrine is a very good, fluorocortisone potentiates, they're very good vasoactive agents. The fluorocortisone is a good volume expander. We can use desmopressin, which doesn't really help the vasoconstriction aspect, but also will be a volume expander. We give fluids and electrolytes 40 to 64 ounces a day. We can give IV fluids every 2 weeks, 2 liters at times. We have to do slow exercises, leg raises, and if we have to add other medications, we can. Sometimes some specialists think you need pyridostigmine for pre-symptomatic acetylcholine potentiation, and there's other agents that we can use. But antioxidants are also a good cornerstone for wellness.
What antioxidants?
Alpha-lipoic acid, the most neurospecific.
How about NAD?
NAD has been shown to be somewhat effective. We use L-carnitine and coenzyme Q10. If people can't tolerate the alpha-lipoic acid, oftentimes we'll go to N-acetylcysteine. But these are all cofactors in the Krebs cycle and the electron transport chain, and we feel that they can facilitate ATP production, which is probably deficient in the cell, at the cell level in these patients.
Is there any role for endocrine modulations?
There probably is, but we haven't studied that. There are some papers on that, but we haven't studied that, nor have we used any endocrine pharmacology or such. I mean, definitely the fluorocortisone, which is a mineralocorticoid, is from the outer layer, the adrenal cortex, is one of the endocrinological agents that we use and oftentimes is very effective, especially potentially in the midodrine and when they're used in concert. Yes?
Is there a predisposition for one or another?
Is there a predisposition to, what did you say?
In the adult population, is there a predisposition to male or female?
Most of the studies say it's a 50% thing, but we see more females, and a lot of them have connective tissue disorders, and they're predisposed to it. So in our clinic, we see more females, but if you look at some of the literature, some will say there's more female predominance, and some will say they're equal. So it's not really clear, but it's not like 8-to-1 females to males like a lupus or something like that, which you can see in those autoimmune disorders. And we personally don't feel this is an autoimmune disorder. There's no universal autoantibodies been identified, and it responds to the modalities we talked about, and the testing we do shows improvement, and I think that pretty much speaks an autonomic dysfunction disorder due to what we say is oxidative stress at the cellular level. Yes?
Have you seen any patients that instead of have chronic fatigue and have other symptoms that you talked about where it's constant as opposed to intermittent?
Yeah, we see them both constant and intermittent in all types of autonomic disorders. A lot of times around, I'll give you an example, menstrual cycle, people will get severe dysautonomia flare-ups, and during the rest of the time, they're not so bad. Or in the summertime, I have patients that have seasonal dysautonomia flare-ups. In the summertime, when the weather's hot, they're extremely heat intolerant, and they can't do well in the summertime, and they can't function because of the heat and the vasodilatation. So those are intermittent. There are reasons why some people have intermittent versus the constant dysautonomia state. So yes, we do see both subsets.